Hi, y'all, and welcome back to Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. In this episode, one of the high acuity nursing episodes, we will look at the second part of shock, the progression and interventions. Sources for this episode include Iggy's Medical Surgical Nursing and Sol's Introduction to Critical Care Nursing. All shocks can be classified as having stages. These stages are known as the initial stage, the non-progressive stage, the progressive stage, and the refractory stage, each which indicates an increasing deterioration of the patient's condition. The initial stage is identified by the baseline mean arterial pressure being decreased by around 10 millimeters of mercury. In the initial stage, the heart and respiratory rate are also increased from baseline, and/or there is a slight increase in diastolic blood pressure. These are adaptive responses of vascular constriction and increased heart rate. In the non-progressive stage, the mean arterial pressure decreases by 10 to 15 millimeters of mercury. Kidneys and hormonal adaptive mechanisms are now activated because of tissue hypoxia in non-vital tissue and organs. Acidosis and hyperkalemia begin to appear. At this time, stopping any conditions or diseases that started shock and providing for supportive interventions can prevent the shock from progressing further. Unfortunately, shock is usually slow to be responded to, and that means that the shock will progress to this progressive stage, in which there is a sustained decrease in mean arterial pressure of greater than 20 millimeters of mercury from the baseline. Vital organs begin to develop hypoxia. This is a life-threatening emergency. Conditions causing this type of shock must be corrected within 1 hour of the progressive stage onset to improve patient outcomes. If left unaddressed, the shock will move to the refractory stage, in which too little oxygen reaches the tissue and cell death and tissue damage result. The body cannot respond effectively to these interventions, and the shock continues. This leads to a rapid loss of consciousness, non-palpable pulses, cold, dusky extremities, slow, shallow respirations, and unmeasurable oxygen saturations. The massive loss of perfusion to all the organs leads to multiple organ dysfunction syndrome, or MODS. This is the sequence of cell damage caused by massive release of toxic metabolites and enzymes, in which microthrombi form. It first occurs in the liver, heart, brain, and kidney. Also, there is a myocardial depressant factor that is released from ischemic pancreas. The most common causes are sepsis, but other causes of MODS include accidents, surgery, hypoperfusion states, and hypermetabolism states. The physical assessment and clinical manifestations are consistent with hypoperfusion of the critical systems, and it includes all systems. So think cardiovascular, including pulses and blood pressure, respirations, including oxygen saturation and skin color, urinary and renal changes, central nervous system changes, including altered level of consciousness and coma, and musculoskeletal changes, including mobility changes. The non-surgical management of shock, therefore, is to maintain tissue oxygenation by increasing vascular volume to normal range, by supporting compensatory mechanisms. A big item is oxygen therapy, including 100% oxygen. IV therapy is also indicated, and it may be that you need multiple ports. For patients requiring fluid resuscitation, normal saline or Ringer's lactate are indicated. Drug therapy can range anywhere from cardiotonic medications for cardiogenic shock, antihypotensive medications for septic shock, and antihistamines and glucocorticosteroids for things like chemical-induced shock. Some of these vasoconstrictors can include medications like dopamine, epinephrine, norepinephrine, and phenylephrine. The team should be aware, however, that under certain conditions, the tachycardic effects, that is, the positive chronotropic effects of these vasoconstrictors, may actually cause more harm than good. And in that case, a medication such as norepinephrine, which has less of a positive chronotropic effect, may be indicated. The nurses should also be aware that in the presence of hypovolemia, vasoconstrictors are actually contraindicated. So, you should test your patient by giving them a fluid bolus to try to see how they respond to that bolus. Other drugs include, as I mentioned, agents enhancing contractility of the heart and agents enhancing myocardial perfusion of the heart. Both of those are mostly reserved for cardiogenic shock. And that does conclude this episode. However, there will be more episodes at a future time. In the meantime, I hope you learned a little bit. I hope you plan on listening some more, and if you are, we'll see you then. Take care now.